have received the minutes from Morgan to review from the last meeting in August. The date was August 4th. If anybody had any concerns, questions, suggestions, changes to the amendments, are there any amendments, please let us know. I don't, Claire, I'm sorry, Morgan, we don't have enough to vote, do we, right now?
No.
Okay, so if you want to just review those minutes, we'll circle back somewhere in the meeting when we get enough for quorum and take a vote on those. And we'll go ahead and move forward. I'll hand it over to Morgan for the work group updates.
Hi, everyone. So I'll be providing updates on the U=U work group, the prevention work group, and the trauma-informed care / cultural humility work group. To start with U=U, so we're still moving forward with the ambassador campaign, and last Friday, or was it the Friday before that? Time is... But the ambassadors did their photo shoots and the photos came out very well. And so the next step with that is we're going to be doing individual calls with the ambassadors to just learn more about their stories, about what U=U means to them and how it plays a role in their lives, and hopefully getting good information to use in the marketing materials that we're going to create as part of the campaign. And we'll also be having an orientation with the ambassadors at the end of this month or early November to kind of train them about appropriately sharing U=U messaging on social media. So things are moving forward really well with that, and we're really excited about that. And then with the prevention work group, they met last Thursday, and we actually had some new people join the group. Or last Wednesday, we had new people join, and that was great. And we're finally, I think, wrapping up the PrEP Access resource project that they've been working on this year. We've decided on a format for the resource and have a tentative distribution plan. So hopefully by the end of the year, we'll be able to get that resource out to the community and move on with other prevention projects. And then Jamie Reagan, who is part of the trauma-informed care work group, sent me some updates that I'm just going to read for you all because it's quite a bit. So I'm going to get those pulled up. Okay, so that work group meets on the fourth Thursday of the month at 1 p.m. And so the group recently hosted a trauma-informed care retreat with 17 stakeholders across local HIV organizations. And that was near the end of August. And I think Dr. Brown shared about that upcoming at our last council meeting. But the goal of the retreat was to share qualitative interview data results and create recommendations for implementing trauma-informed HIV care in Nashville. The recommendations created during the retreat, as well as the interview themes, were then shared with HIV care leaders at a luncheon immediately following the EHE Summit on September 30th, so last Friday. And Claire is going to be giving a recap of the summit in a bit. And also, Dr. Brown was recently awarded a P50 grant through the Southeast Collaborative for Innovative and Equitable Solutions to Chronic Disease Disparities. 11,050 surveys with HIV positive patients across the Southeastern United States will be conducted for the Advancing Culturally Responsive Trauma-Informed HIV Care in the Southern United States pilot project. The instrument is the Organizational Trauma Resilience Patient-Reported Experience Measure, which is a tool based on the validated Organizational Trauma Resilience Assessment Personal Reported Outcomes. And that focused on staff perceptions of organizational resilience. And next, the group will be planning an HIV trauma-informed care data summit to share their findings and recommendations with a larger group of stakeholders, and that's going to be happening at some point this winter. And I can send that to you in email format. I don't expect you to retain everything that I just said. But yeah, so that is it for the work group updates. Does anyone have any questions about any of that? And I think we have quorum now. 1, 2, 3, 4, 5, 6, 7. No, not quite. Okay, so I guess we can move on to the new business, Claire.
Yeah, Morgan, are you able to share the responsibilities?
Yes.
We thought it might be helpful since there are some newer people on the council, and actually there's a few folks on today that have not been officially appointed yet by the mayor, but they've been voted on by the council and sent to the mayor's office for appointment. So we're just kind of waiting for that process to play out. So especially for anybody who's new on the call, but I think it's a good refresher for others as well. We thought it would just be helpful to share the authority and responsibility of the EHE Advisory Council. So the council shall serve as in an advisory capacity to the mayor and is charged with guiding the implementation of the EHE plan for Nashville, including prioritization of the recommendations, ensuring that principles of health equity and social justice are incorporated in the process, and that the goals, objectives, and action steps involve conscious efforts to reach communities that are disproportionately impacted by HIV, working to ensure that institutions that create, manage, and distribute resources that directly impact the Nashville communities understand the responsibility of ensuring equitable resource allocation, and that efforts and assets are directed towards populations that have historically been disproportionately impacted by HIV. And last, establishing strategic priorities and mobilizing collaborative and effective community initiatives to achieve the goals and objectives of the EHE plan. Does anyone have any questions before we move on? All right. In that case, I wanted to share a little bit about what we did last Friday at the EHE Summit. And Morgan, can you give me the ability to share my screen? I have a couple of slides on this. All right. So we hosted the EHE Summit last Friday, September 30th. So the purpose was to kind of catch everyone up on EHE so far, hear from work groups on project updates. And these last two bullet points are what I'm going to be talking to you most about today. We did some strategic planning that was requested by our partners at Fast Track Cities, and we discussed new work group projects. Before the conference, we did a little survey to everybody who had registered, mostly to find out what work group they might be interested in joining. But we also asked them what would encourage them to become more involved in Nashville's EHE efforts. And I wanted to share the results because those were interesting to me. So the top two responses were work groups focusing on specific issues I care about, and clear objectives for the overall project. And then the next two were also pretty highly ranked. One was my employer making EHE work an official part of my job responsibilities, and making EHE work the other one was allowing time during my work day to spend time on EHE work. Sorry, copy and paste issue there. And then a few people said they were already involved in EHE, and a couple of people said that they were unlikely to become more involved in EHE, although hopefully they changed their position on that after the summit. we also did a little bit of strategic planning. And again, this was requested by Dash at Fast Track Cities. This strategic planning was supposed to take place during the Fast Track Cities implementation workshop, but there wasn't time to do it then. So we decided to do it at the summit. And we broke out into 3 groups, and each group was focusing on one of these questions. First question was, how do we maintain political commitment to HIV in the midst of the local COVID-19 epidemic and other future epidemics? Question 2, how do we sustain long-term participation of and create leaderships for key populations? And question 3, how do we tackle systemic racism, inequities, and inequalities that threaten public health and social cohesion? So as you can see, these are really big questions. We only had about half an hour to discuss. So the responses to this are really just sort of a start to answering some of these questions. But I wanted to share a little bit about what people came up with. So for the question about maintaining political commitment during epidemics and pandemics, looks like that slide got cut off, but one of the major objectives that came out of that one is to just increase local political engagement within our community. So continuing to educate politicians, making politicians aware of events related to EHE and encouraging participation, mobilizing faith-based organizations to help advocate for HIV services. And I think that last one was follow up with, just continue following up with political leaders to ensure that our goals are actually receiving attention. And then on the question of sustaining participation and creating leadership roles for key populations, this group talked about increasing support services, including things like childcare and mentorship, making it an organization's responsibility to be informed and not taxing one individual, and limit sort of cherry picking people as sole representatives of a larger population. Shift meeting schedules to accommodate key populations, compensate time if it's outside of their position, create positions specific to key populations, host workshops on communication and education and cultural humility, and improve processes for disseminating needs assessments in key populations. And then on the question of tackling systemic racism, inequities, and inequalities, the group talked about one objective being to identify diversity deficits in priority organizations, including increasing diversity in leadership and decision-making positions and reducing minority burden while ensuring impact. And then another objective was to decolonize tools. And there was a really interesting conversation around this. So the idea is to ensure that tools and policies center key populations. And an example given was that in the development of the HERE risk assessment, Black men were underrepresented in the development of it. And so that tool didn't end up being very good as a risk assessment tool with that population. So talking about ways that we can be developing new tools that are centering key populations. So after the strategic planning aspect of the conference, we broke out into more work groups, and these work groups focused on 5 different topics. And the hope is that after the conference, the people who participated in these work group discussions will continue to participate in EHE, and that these will now be work groups that are sort of independent of that summit, and that those folks will continue to engage and also potentially bring in other people in the future. So we're going to hear about the equity work group in a moment, but they're going to be transitioning to more of a focus on social determinants of health. So one of the work groups broke out and discussed that topic. We also had a work group discussing prevention, another discussing HIV testing, and another discussing data. And each of these work groups were given a printout of specific objectives and action steps from the Nashville EHE plan relating to their topic. And they were asked to come up with ideas for different projects that could relate to those aspects of the EHE plan. So a little bit about what the prevention work group discussed. They talked about finding ways to improve tracking of PrEP across all the different sites that are providing it, And one suggestion was to consider finding out how AIDSview tracks this. Nobody that was present really knew how they do that. Build an online referral database to help people navigate by insurance status, location, et cetera. And this would build upon some of that prior work that's already being done by the prevention work group. Focus on increasing prevention outreach efforts on primary care providers and actually allocate resources to that. Focus on ways to increase PrEP among minorities, and locating subgroups in the community to target PrEP uptake. And then there was also a discussion about PEP and developing standard operating procedures across Nashville EDs, having an automated workflow in the EMR, and developing follow-up and handoff procedures that are consistent across Nashville. And one thing I loved is they kind of ended their discussion by talking about how each of these items could be different breakout groups for a future prevention work group meeting. The social determinants of health group talked about promoting a find help approach similar to HMIS via HUD, creating a referral and communication system regarding social determinants of health needs. And this can bill for prepare, not exactly sure what that is. I just put it was in the notes. Adopt a housing first approach, noting that there is rapid rehousing, but not enough places are taking vouchers. So addressing imminent issues of criminal records and expand landlord incentive, more data on housing as prevention, and a community health worker model, which would keep specialized navigators, but create synergy among them. The HIV testing work group talked about having workshops to help healthcare workers buy into the importance of HIV and STI testing and helping people understand that people can have HIV and STIs without symptoms. Promote consistent testing and increase programs to help meet people where they are, and this will require extra funding. And then there's a specific portion of the EHE plan that relates to acceptability of HIV testing. And this group noted that acceptability has to start with healthcare workers and healthcare workers being tested regularly and of course confidentially, and shift from intimidation to empowerment and enable conversations about HIV. And then promoting access to professionals to speak with and ask questions about testing. And then last, the data work group. I just want to note that this was the smallest work group. There was the most interest in this work group before the summit, but it ended up being the smallest one at the summit due to a lot of people who didn't end up being able to attend. But the data work group did talk about a few things. So determining what data is available and who has access to it. So including but not limited to Metro, TDH, Fast Track, and individual organizations. Improve data access to allow agencies and EHE to know how they're doing. The need for epidemiologists to be funded to participate on a data work group. Model goal tracking on the model that Memphis has developed. So there was a lot of discussion about what Memphis EHE has done. And Memphis, unlike Nashville, is funded as a priority jurisdiction for EHE. So a lot of the discussion centered around what would Memphis be willing to share with Nashville in terms of a framework for tracking data and things like that. And then host a data summit to bring together some key stakeholders. And just to note, there is a section of the EHE plan that I wanted to highlight today about overarching data activities. And this is something that unfortunately we have not really been doing much of yet. And I think it's important that we think about focusing in more on this in the future. So the overarching data activities include coordinating definitions and data related to HIV prevention and care interventions across state and local levels, including measures related to experiences of stigma and interventions to address stigma. Enhance collaborations between HIV prevention and surveillance programs at the state and local levels. Collaborate with oversight body and EHE coordinator to monitor and report on progress, including the EHE website, and consult with oversight body and EHE coordinator to respond to evolving data needs. So a few challenges related to the summit. We did have really low turnout, unfortunately. A lot of key stakeholders weren't present, but I think the people that were there had a really great experience. I didn't realize that it was being hosted the day before the AIDS walk. So I suspect a lot of CARES people that would have wanted to attend were kind of in last minute prep mode and weren't able to. There may have been other things going on that I wasn't aware of too that didn't allow people to attend. Also, limitations related to funding, of course, that's always an issue. And then limitations related to employee bandwidth to contribute to EHE, and the need for space to be given to employees to participate in EHE activities and potentially even be funded as part of their official job description to work on EHE. And then some successes. So there was really great diversity in terms of age, gender, race, ethnicity, discipline, and different organizations represented. So Vanderbilt, Meharry, Matthew Walker, Mental Health Co-op, TDH, Metro Public Health Department, Streetworks. It was, and there were more as well that aren't listed here, but it was really refreshing to connect with everyone in person. And what was really, I think, the most exciting thing for me was just seeing how many people attended that have not been involved in EHE at all prior to this point and are now excited about being involved. So next steps, hopefully capitalize on the momentum of the summit and form new work groups, convene meetings, and begin to identify some potential leaders. We're also going to share this information with DASH at Fast Track Cities, and they have been really excited to try and connect us with some other cities that are part of the program that are similar to Nashville in certain ways. And so we're going to ask them to help us with some cities that can sort of help us to achieve some of these goals. And then last, we're going to continue working on our data structure. I do think it would be great for us to be able to host a data summit and use it as a jumping off point for a data work group. And I am happy to host and facilitate a data summit. And that certainly falls within what we can do as the AETC, but I am definitely going to need some help from people who are more data driven, more data people than me. So I know that Meredith Brantley isn't on today, but I'm definitely going to need her help with planning this. I am not necessarily the most qualified to plan the content for a data summit, but would welcome anyone's input as to what they would like to see at a summit like that. And that is it. So I will go ahead and stop sharing and just ask if anybody has any questions about the summit or what our next steps are. And if not, we can just move on to the next item on the agenda, which is discussion.
I have a question, Claire.
Oh, yeah, go ahead.
Yeah, thank you for the great summary. And I resonating with a lot of the things that came up from different working groups, but I think from, as a researcher, I've been thinking a lot about the social determinants of health side of things and structural interventions. And there were some really concrete thoughts about, housing instability and housing benefits. That was one thing that stood out to me. The other one was around the on the PEP protocols, kind of harmonizing things across institutions. I am curious about next steps on how we can specifically leverage the expertise and roles on our group to further these. So I'm just I guess there are, and since I'm still fairly new, I'm not sure how we follow up on some of these priorities and make them into specific action items. But I have some thoughts on a couple of these and ways that I can probably participate in some of these working groups. But I'm curious on your thoughts about action items for next steps and what what other things you may need from us. You mentioned some things around the data, but.
Yeah, that's a good question. And I think, you know, one thing I want to recognize is that a lot of people on the advisory council may or may not have time to be a part of a work group. Depends on the work group, but a lot of work groups are meeting kind of more frequently, maybe every other week. I'm not sure how often all of the work groups meet. So if you are able to join a work group, I think that's the best step forward. But otherwise, I think our next steps are just to start convening some work group meetings and making the call out widely to ask people to join, of course, engaging the people that were at the summit and participated there. But, and then, you know, if people from the advisory council are not able to be part of the work groups, but want to stay updated on what they're doing, we'll continue to have these regular updates in our advisory council meetings. But yeah, without joining a work group, it's tough to have a lot of impact on the kind of direction that things go. Specifically with PrEP, PEP, I learned something new from Sean yesterday about how PEP is done in the ED at Vanderbilt. And I don't know, maybe you can speak more to that, Sean, but my understanding is that Vanderbilt has a relatively new process for PEP that was kind of recently developed and might be something that can be expanded, and some of those protocols and things can be shared with other EDs across the city. And yeah, Sean, do you have?
It was years in the making. You know, prior to this, I don't know how new it is, maybe a year or two old, but prior to this, Vanderbilt didn't really have an NPEP, a non-occupational PEP program, and so what we in ID developed was a protocol where somebody who's a typically survivor of sexual assault seen in the ED would be given a dose pack of PEP, which at the time was Truvada and dolutegravir, a 3-day dose pack that the ED pharmacy created, which wasn't a lot, but just enough to bridge them to an urgent visit in the infectious disease clinic where we would take over and work on getting them a supply of a 28-day supply, which typically came from our MAP grants because it's so expensive to use insurance. So this worked sort of, and so the ED kind of took it upon themselves. So I was really impressed that their pharmacist had a QI project, I think, and the outcome was they would send the patient home with 28 days of the Truvada dolutegravir, which gave us a whole lot more time to see them in clinic. And that's what's going on, my understanding. We really haven't seen any urgent cases since that project was implemented. So took a long time, but you know, I think the Vanderbilt ED is finally doing it well.
And Sean, do you know, is there something, is there some way that, does something pop up in the EMR or something when someone comes in after a sexual assault that says, you know, consider PEP, or is it just kind of on the individual provider to know what the process is?
It would be on the individual provider. And initially we had circulated it widely in the ED so that it was a well-known process. And this was through the general ID clinic. And so our nurses knew exactly what to look for and how to get the patient their medication through the MAP grant. Now I think it's just a well-known process through the ED.
Okay, great. Did that help answer your question, Dr. Honke?
Yeah. I mean, I think that is helpful, and I guess it's also just knowing if there are specific asks from the working groups that we can provide, you know, any other resources for. Because I was thinking specifically about, yes, you know, Vanderbilt certainly has a protocol that could be shared, you know, just as you were suggesting. But it's kind of things like this, in addition to, you know, whatever else we may contribute to direct working groups with time.
Yeah, I definitely think that there will be, and that's why I do think it's important to have those regular work group updates, because I suspect one thing that's going to continue to come up is funding needs and just help finding funding and asking members of the advisory council to help advocate for grants and things like that, and help locate funding or use their institutional funding to assist with projects.
Yeah, that's great.
Any other questions about the summit or kind of what we're going to do moving forward? So next, I'm going to hand it over to Dr. Leah Alexander, who was kind enough to join us at the last minute today, and to give everyone a little bit of background about the equity work group has been meeting since the beginning of this process and was sort of the first thing that the advisory council said should be created to ensure that all parts of the EHE plan are being developed with an equity lens. So the equity work group has been working on that equity lens for a couple of years now, and they have achieved what they set out to do, and are going to be sharing that with us today, and moving forward are going to be continuing to meet, but shifting focus to more of a social determinants of health lens. So Dr. Alexander, would you rather us play the recording from the summit, or do you just want to go ahead and share live with everyone? Oh, you're muted.
I can try to get to my slides. Maybe that would be the best use of time.
Okay. That's fine. Whichever way you want to do it. We have the recording queued up if that's easier for you.
Well, you don't want to play the whole thing, I'm sure, so.
Well, it was really interesting, but.
Let's see if I can. I don't have the best luck with WebEx, so you may have to help me out a little bit.
Oh, Morgan, you may need to.
Yeah, I just made you a presenter, Dr. Alexander.
Okay, so let me see here if my presentation is open, but I don't see how to share. Oh.
If you go to the menu bar,
Mm-hmm.
and then share should be an option, and then you can share content.
Okay, let me see where I am. Oh, goodness. I think this is the screen I want to share.
I also see that you can look at the bottom of the screen.
Oh.
Can you
Right,
guys see
share
my
there too.
slides?
But you got it. You got
Okay.
it, got it.
I don't know where I am, but okay, if you guys can see my slides. And I think we're good. So I'm happy to share these slides, and I won't kind of go through all of them, but maybe just some of the high points of what we've been doing with the equity lens. So now let me see, how do I move things forward? Because, okay, I'm on two screens, but it's doing something weird. So for this particular work group, we were tasked with prioritizing and implementing equity-focused goals, objectives, and tactics, and to serve sort of in an advisory capacity to the council. And one of our main activities, I think, and we started this before the pandemic, was to work to develop sort of an equity lens process that other work groups could use, and even, you know, folks involved in EHE work, maybe even outside of some of our specific work groups, to, you know, see where your organization is as it relates to equity, sort of starting with some questions that you could ask yourself. So we spent quite a lot of time looking at existing models and trying to come up with something that might be useful. So let me see here. I'm advancing in 2 different places. So there are already several resources available that, you know, are touted as equity lenses or questions to ask or ways to think about, you know, how your organization is practicing equity in their decision making. And a lot of our early conversations started around Kamara Jones's work, and I think mainly because so many of us are fans of her work, and so we reached out to her and we're, you know, trying to think about maybe a way to take another look at that allegory, to use that to start the conversation. But I think we got down a rabbit hole a little bit, but again, that's because we love Kamara Jones. And so we decided to sort of circle back to some of the existing tools. And we see this lens, you know, one to sort of, again, assess your work, perhaps your organization, but also to be a conversation starter. So if I do this, and then I have to click over here so it'll advance. So we also spent a lot of time, you know, refining our definition of radical inclusion. So I won't read you that slide, but again, I will share it and make sure that you all have it. So there were several tools that we worked through and sort of looked at to see if we wanted to adapt them for this particular use. So the first was the Awake to Woke to Work model. And it's developed by Equity in the Center to help sort of shift mindsets, practices, and systems. And it sort of level sets by being very specific around their definition of race equity. So the condition where one's race has no influence on how they fare in society. And then also race equity culture, which is focused on proactively counteracting race inequities inside and outside of an organization. So this particular model, and forgive me because for some reason my advancing is not working. Anyway, so this particular model we liked because it really spoke to all members of organizations, and you're asking yourselves questions and kind of putting yourself, your organization, your leadership into 3 categories. So either you're awake, woke, or you have work to do. So people could use this even to assess themselves, assess community, the people that we serve. I particularly liked this one a lot, but there were others that we wanted to take a look at as well. So the next one that we sort of considered is the Equity and Empowerment Lens, which comes out of Mononta County. So this particular one is used to establish equitable, diverse, safe, and inclusive workspaces. It's a quality improvement tool used for planning, decision-making, and resource allocation. And so this one actually sort of presents the 5 Ps, and they sort of develop this worksheet. Let's see here. Okay. Where you are asking yourself a series of questions around people. So, you know, the positive and negative impact of whatever the issue is that you're dealing with, how people differently situated in terms of barriers, and are people traumatized or re-traumatized by the decision or the issue. And so this circle wants us to consider physical, spiritual, emotional, and contextual effects of the issue. Then you ask yourself a series of questions around place. So how are you or this particular decision, this activity even, accounting for people's emotional and physical safety and their need to be productive and feel valued? How are you considering environmental impacts as well as environmental justice? And how are public resources and investments distributed geographically? And then the next one is process. So how are we meaningfully including and excluding people, particularly communities of color who are affected? And what are the policies or processes, social relationships that contribute to the exclusion of communities most affected by inequities? And then the power questions. What are the barriers to doing equality and racial justice work? What are the benefits and burdens that communities experience with this issue? Who is accountable? And what is your decision-making structure? So just to sort of put this one in context, people would use this 5P worksheet, thinking about an initiative, a decision, maybe a program that you're planning on implementing in your organization. You could use this worksheet to kind of think about what your work group is doing and how you're able to answer these questions. And so folks liked this one, but we kept going, and actually Julie found one other one, and it's actually the one that we sort of landed on. So this one is Smarty. So we liked this one because it's adding inclusive questions and questions around equity to what we already use, which is SMART goals. And so we thought that this one was probably going to be most useful for individuals, work groups if they wanted to work through this lens, even if folks wanted to use the equity lens to sort of evaluate their organization, because so many of us already have been trained in and use SMART goals in the work that we're doing. So basically it's, everything that you've been trained to do with the S for specific objectives, making sure they're measurable, action-oriented, relevant, and time-bound, but then you're adding questions about inclusivity and equity for each of the letters in our traditional SMART goal model. So this is the one that we landed on. And so we use the SMART goal model to develop what we're calling our equity rubric. And so it's been programmed in REDCap, and we were sort of aiming for a mixed method approach. So there's, quantitative responses, but also opportunities for people to, sort of type in more long answer or qualitative responses. Because it's in REDCap, we can distribute it with a link or either a QR code. And so some of the questions in our rubric: what is it that you want to accomplish with your project? How have you included community members who are most impacted? What extent have you assessed support and buy-in for this project from the persons directly impacted? And to what extent have you considered unintended impacts that would increase burden or worsen outcomes? And what's the extent you've considered the impacts of timing of this project on the priority population? And so from these types of questions, the responses are scored, and we could actually, compute a score and then, put people in categories based on, doing a good job with being inclusive and focusing on equity, and then maybe, where you have to do a little bit of work. So that's the idea about how this rubric would work. So our next steps are really to pilot it. And I think the ask that I made in the presentation was just if there are people who are sort of interested in this and would like to come along with us. Maybe there's a work group that wants to do this, or an organization that might want to, convene a group of people to work through the rubric and help us just make sure that it's working the way that we want it to work. And then thinking about how to disseminate our scores, right? Rubrics kind of give you a score to tell you if you're doing a good job or if you need to work on something. And then some of the other issues that we have talked about is just how to share the information, and then the so what piece. Because what happens oftentimes, you tell people that they maybe need to work on this in their organization, or, rethink the initiative, or do a little bit more, work around the decision. But what are the tools so that they could, have to begin to think through this process? So it's not really fair. And we do this, in community health education and promotion. It's not really fair to tell people that they're not doing a great job and not provide other resources. So we have the rubric, but what would be the next piece or resource for folks if they, in fact, found out that they had a little bit more work that they needed to do? Other issues are, of course, sustainability. So and that kind of ties into that so what piece. What would be the next step? So if people are engaging and using the rubric, how would we sustain this over time? The way that it's programmed, people could get their score and they could, know what the score means. But if we keep the qualitative questions in there, somebody would probably need to be on board to maybe focus on that analysis. So one of the things that we talked about was leveraging public health students. So I'm currently hoping to identify a student at Meharry that might be interested in helping. But I thought it would be a wonderful opportunity for us to also partner with the public health programs across the city. And that might even help us with sustainability. So that's where we are. I mean, it's moving and people are thinking about how to, measure it and come up with a tool that is useful. But if there are folks who could, maybe actually use the rubric and, meet with us so we can get your feedback on it and get maybe some ideas about improving it before we do a big rollout, that would probably be very helpful. So that's all I have. Now I have to figure out how to stop sharing, and I'm happy to answer any questions or take any suggestions people might have.
That was really, really informative. I just want to thank you for that. I have a question, and you may have said this before. I've been in and out of this call. Is it possible to have that presentation shared with us?
Absolutely. Yes.
I would love to look at that again.
Absolutely. And I think, Claire, I sent you the link, but I probably didn't send you my slides. But I will absolutely do that before we finish up here today.
Thank you so much.
And I can share the recording with you. And I think I honestly think just about all of the current work groups probably have something either almost complete or sort of in the works that fit from kind of pushing through the lens here and seeing what comes out. So I think probably the best way to do that is Morgan, maybe we can I don't know, Morgan, are you on all of the work group calls or?
No, just U equals U in prevention.
Okay.
But just seeing the presentation for the first time at the summit, I was telling Claire, I really feel like we could apply it to the U equals U project right now.
Okay.
And one of the prevention projects too. So it's very exciting.
Okay, well, we'll make it available for folks.
Yeah,
And
maybe.
then if they're, just, after people do it, if there would be some folks that would just be, available maybe for a short little question and answer interview on, after, we could use that as our pilot, just to make sure that we've gotten all the bugs out and included any sort of input from other stakeholders.
And you mentioned that it doesn't necessarily need to be EHE work groups. And one thing that I have just been thinking about a lot lately is that there are a lot of things in the EHE plan that are being pursued independently outside of the structure of EHE and the work groups and the advisory council, that individual organizations are always working towards these goals. And so I think there are probably a lot of opportunities for organizations. So, I just would encourage everyone on this call to think about projects that you have in the works, QI projects or anything else that would potentially benefit from using this equity lens.
Well, we'll make it available.
Thank you so much, Dr. Alexander. I asked you very last minute to be on this call, so I really appreciate you taking the time today.
No problem. And call me Leah, please.
Did anyone else have any questions before we move on? All right, in that case, I will kick it back to you, Morgan, for some nomination updates.
Okay, thanks, Claire. Hi, everyone. So as I said in the email I sent you all yesterday, all of the nominated, all the folks that were nominated for the advisory council have been approved by majority votes from you all. And I sent those names. Brandon, did you get my email that I sent to you and Tom with the names of the applications of those 5?
I did.
Okay.
Did Tom respond to you? Because he normally handles that.
No, he hasn't.
Okay. I will check with him.
Okay, sure. Thank you. So hopefully our next meeting is on December 1st, which will be the last meeting for the year. So hopefully we can have those folks officially approved and they'll be able to join as official members of the council for that last meeting. And I invited them to attend today just to see what the meetings were like. And so I think we have Dr. Link with us. Hi. Thank you for joining. But yeah, so thank you all for filling out the survey and submitting those votes. And very excited about the 5 new potential members. Does anyone have any questions about that?
Morgan, just the only thing, December 1st is World AIDS Day. A lot of us in this group may have a lot of stuff going on that day. It may be just worthy of a discussion to see if picking a later date might be better.
Right. Thank you for pointing that out. That did not register at all. Yes. So probably the following week would be a better day. I will send that update. Does everyone agree to move that from the 1st? Yes, I see some nods. So I will send that out to everyone and we'll see who can attend on the following week. Thank you, Brady. Yeah, so I guess I'll kick it back to Claire for any questions or concerns anyone might have.
Yeah, just have a few minutes here. I think technically the meeting goes to 3:30, but we're not going to need that much time today. But does anyone have any questions or concerns they want to share now?
Hey, all. I wanted to give you all an opportunity to discuss the recent changes at the Music City Prep Clinic that we sent out to community partners Those changes went into effect on October 1st. If you think it's useful for you to try to summarize them, I can. Otherwise, if you have any questions for me regarding the changes, this is maybe a good time to field them.
I think it would be helpful to give a quick summary for people who may not be aware of the changes.
Okay, so these changes are more than a year in the making. About in October last year, at an all hands meeting at the PrEP clinic, I used the metaphor of the Titanic to describe not only the Music City PrEP clinic, but the national HIV prevention strategy based on the 340B model. It's a model that is destined to sink at one point because of the way the insurance companies and Gilead can work together unilaterally to decide whether or not they're going to cover PrEP at all, or if they're going to continue, or if they're going to continue to charge higher prices each month for the PrEP. So what we needed to do was, first of all, address the uninsured patient base, because when Gilead decided to take off the table all the revenue related to uninsured patients, for most PrEP clinics around the country, that meant 50% of the revenue would leave the clinics and head back to Gilead. So there were three major initiatives that we had to put in place over the last 12 months related to these changes. The first one was how to replace the revenue lost from the uninsured patients. In other words, we would still need to see and treat the uninsured patients because that's the mission of a nonprofit. But how would we support it? And so the goal was to insure the uninsured, meaning that we would have a team of navigators and get them all onto ACA insurance at the cost of the PrEP clinic. So the PrEP clinic would pay the premiums for the ACA insurance, and then that would then generate the revenues for the prescriptions needed for PrEP. The unadvertised bonus to that, of course, is that for the first time in many patients' lives, they actually had a decent health coverage to cover all of their healthcare needs, not just PrEP. So we did that last year. Last November was the first open enrollment period, and that was a huge success. And we bumped up our insured uninsured mix from about 55% insured to more like low 80% insured, which was really a great accomplishment in just 4 to 6 weeks of enrolling patients as fast as we could. Of course, once the window closed, we continued to take on more uninsured patients, and then we got back to almost that 50-50 again. So this November, it's open enrollment again, and we're going to do an even better job of insuring the uninsured. The problem, though, as I mentioned before, is insurance only works if the insurance companies agree to cover Descovy, and if Gilead doesn't keep raising the costs of Descovy each month. If the insurance companies insist on generics or Truvada, that's really good for one aspect of it, but it doesn't cover the full costs of care or the advertising to pull the patients in the first place. So what has been clear to many people around the country for a long time is eventually this model is not going to work as the cost lines and the revenue lines cross. And so one of the things that we needed to do is limit the new uninsured patients that we take on. And that's one of the big changes that we did October 1st, where before we would educate the entire market and say, come one, come all. If you're interested on PrEP and you're a sexually active adult, come see us. And that was a very successful program. And just yesterday at Metro Health, they told us that because of this program, we are seeing way more people get checked for STIs that otherwise wouldn't be doing that because of the outreach of the program. So we have been adding about 600 new patients a month under this model, and half of them are uninsured. 35% of them are from the Black and African American communities. Okay, so going forward though, from October 1st, in order to keep afloat, we're going to have to reduce some of these costs, and that would be restricting the STI testing and treatment program to what I call PrEP protocol driven services. So if you are getting services that are driven by PrEP protocol or ART protocol, then we can continue to provide those services and provide financial aid for those services. But if you're coming just for STI testing and we are unable to convince the patient that if they are sexually active and concerned enough to be tested for STIs, that therefore they should be concerned about HIV as well. If we are unable to convince them after 6 months of our adherence and retention teams speaking to them, then they will start to face the actual costs for the testing. All right. And what we're going to do for the rest of the fiscal year, for as long as we can, we're going to buffer those actual costs and match Metro Health, which is $10. So they can continue to see us, or they can go to Metro Health. But what it means is for the non-protocol patients, there will be at least a $10 charge if they are uninsured. Okay, if they are insured, then it'll be however the insurance works out to be. So that's one of the big changes. Another change is we have to limit the numbers of STI patients in general that we'll see in a month, as opposed to everybody that comes through. So there's a limit on financial aid, and there's a limit on the number of STI patients. The financial aid is need-based. Are there any questions so far? That was a lot. Okay, thanks, Brady. I saw the thumbs up. All right, so the other thing that I want to put out there is this is a set of initiatives that will work so long as some insurance companies will cover Descovy, and so long as Gilead doesn't continue to increase the costs of Descovy. Because as you know, 340B clinics depend on the profits from PrEP to succeed, and the profit is in Descovy. So if the continued pushback against Descovy persists month after month after month, it's very likely that everything that we've been reading about PrEP failing around the country, and at least in the 340B model, will come home to Nashville. And the Music City PrEP Clinic is going to have to restructure around other business models that aren't dependent on 340B. And that will be a dramatic change. Sean mentioned at the ribbon cutting last year that prior to the Music City PrEP Clinic coming to existence, Tennessee as a state was in the lower percentiles for PrEP uptake in the country. But since MCPC has been in existence in just a few short years, Tennessee has been catapulted up into the top 5 states in the nation for PrEP uptake. And if Davidson County, in its own right, were a state, we would be the 4th most successful state in terms of PrEP uptake. So what this has been is it's a case study on how much it costs to overcome the barriers of care, to get as many people informed about PrEP in a community, to get as many people as possible that are interested to get a prescription, to reduce the anxiety and concerns enough among Blacks and African Americans that we can actually increase our new patients to 35% representing that community, These are all successes, but it comes at a cost. And we know exactly now how much it costs to buy the number 4 spot in the country. All right. But what I'm warning is because the 340B model is unsustainable, we're not going to be able to continue to invest in the community at the rate that we have been. And so that top spot of number 4 or 5 in the country now is at risk, where we could slide back down to where we used to be. So, I think it's appropriate for this committee to think about how we would position the value of that spot of where we are in the nation and where we've come as a community, and whether we want to keep it or not, and whether or not the community and our political leadership is willing to figure out a way to keep that top spot. Did that take your breaths away?
I mean, I think just for me, it's been a little bit. I think I was a little bit in denial before October of just how big an impact it was going to have, and it's the reality is kind of settling in now, and it's just really unfortunate for our community that that these changes have happened. And yeah, I do think you're right that this council has a responsibility to think about what we can possibly do to, I don't know, to push back on this, or find ways to sort of decrease the negative impact of these policy changes. I don't have the answer, but I thank you for sharing, and I certainly agree. It's something we need to be thinking about.
I mean,
Am I allowed to share my screen?
Yeah, Sean. And I also want to point out, I just, look at the number of PrEP prescriptions that we alone did last month, 3,600.
My computer exploded when I tried to share my screen. Can everybody see what I'm sharing right now?
Yeah,
Yes.
but you can, go to slideshow and.
Teams in my computer.
Click from beginning on the far left there, Sean.
There we go. So these are slides from AIDSview that they dumped a lot of data this year, and a lot of them are in really useful infographics. And so I just want to bring you through a couple of slides to illustrate what Rich was talking about. So a new metric that I heard of this year is called the PrEP to need ratio. And this is the number of people on PrEP per the number of people infected with HIV, new incident infections in a geographic region. So there's no benchmark of what a PrEP to need ratio should be, but the higher the better, the lower the worse off the region. So we in the South have the lowest PrEP to need ratio. So for every one person infected with HIV, there's only 4 people on PrEP. And we have a number needed to treat for PrEP that's somewhere between, depending on the demographic you're looking at, 11 to 40 or 50 or so. So we have a lot of work to do. And this is why PrEP to need ratio is important. So when you look at over the last 10 years, increasing PrEP use among Black, Hispanic, and white people in the United States, it seems to be pretty consistent among all those groups. But that doesn't take into account the disproportionate infections among people of color. And so PrEP to need ratio does. And you see that the consistent increases, uniform increases in PrEP use does not overcome the discordant rates of infection among Black and Hispanic people in the United States. And you can see that on the right. So the PrEP to need ratio is the worst in the South, and the states around us like Alabama, Mississippi, South Carolina have some of the lowest PrEP to need ratios in the United States. And for the sake of this analysis, Puerto Rico was included, which has absolutely the worst. But nonetheless, the worse off states are the states surrounding us, but not us. frozen? Here we go. And so here is where Tennessee kind of enters the picture. And I think it's undoubtedly thanks to Music City Prep. So this is the 5 states with the largest increase in PrEP use rates between 2019 and 2021. So the biggest increases, accelerations of PrEP prescriptions, Nevada, Oklahoma, Florida, Idaho, and then there we are. So we were getting the most people on PrEP among the top 5 nations, getting the most people on PrEP during those years. And then you look at the per capita PrEP use, and the states that are doing the best, it's no surprise, Washington, D.C., New York. But if you look at Davidson County as if it were its own state, we would be number 4 for per capita PrEP use, which I think is undoubtedly thanks to Music City Prep. And so these are huge gains that we've made in Tennessee that have taken us out of the bottom rung of the United States that, as Rich was alluding to, we can't really risk losing these inroads. Stop sharing.
Yeah, I appreciate that, Rich and Sean, that I think that's really been, the uptake has been awesome. But I think what's really critical moving forward, even with all the changes, is what you spoke to, Sean, of the disproportionate impact on Black and Brown communities. I think PrEP's uptake in Tennessee and also in Nashville, as we look at it, has been a true challenge among those disproportionately affected Black and Brown. And so I think that the strategy is, and understanding that 340B is being attacked, but really importantly, and I think this is something that all of us that have been doing a lot of work in this community need to think about, is talking about the equity group and looking at it from a racial lens of what do we need to do to really reach the communities that we're not reaching. I mean, we have saturated markets in dominant race, but we have struggled really in looking at minorities and communities of color. So as we move forward, I think this council, and I think it's really important, what are we going to do to address systemic racism and issues that really impede us from truly penetrating and understanding the barriers and struggles of communities of color, especially the Black community. But I appreciate, sharing all this work and appreciate all the efforts that are happening.
I would like to, at some point when you all feel that it's you're ready to do it, is look at the investment that we made in the Black and African American communities over the last year, because it was a corporate objective to get us to over 35% of new patients coming from those communities. It involved focus groups to help us do billboard campaigns, and also special television commercials that were directed at those households. And then finally, partnering with pastors in the counties outside of Davidson County, so that after church, there's usually a radio talk show to discuss what was discussed, and the host and the pastor would basically talk in a PrEP commercial. So it didn't sound glitzy or flashy. It was part of the discussions, and it sounded like the voices on the radio discussing the service. So we have made many inroads, at least with the Black and African American communities, I think, to get us to 35%. I don't think what Sean's graph shows, and maybe I missed it, but we need to see if there's data showing that the disparity is not as much in Tennessee as it might have been as a trend in the other states. I'm not sure.
Another job.
I haven't seen data that granular.
Neither have I, but I think looking at the number of folks that potentially from Black and Brown communities that should be on PrEP, and I think the problem is access, and then also retention and keeping folks engaged in care and alleviating those barriers. I think we can get PrEP out there and folks can start it, but are they really continuing it? And what are the prevention messages and barriers that we can overcome to really support communities to be adherent long-term? And so I think there's deeper issues that we need to look at as we move forward. And so I think those are some of the things that, we at Nashville Cares had to really step back and take a hard look to really see how do we engage those communities and also engage them to tell us what they need so we can be relevant and appropriate. Because sometimes we think we're doing messages that resonate with them, but sometimes we're really hurting communities more than we're helping them. So I just think we need to really be mindful of messaging and things that we think work for certain communities and certain populations and certain people, when sometimes we're doing more harm than help.
And I do want to recognize, you know, of course, Music City Prep is a huge player in the prep game, and but you know, there have been other organizations also doing awesome work in terms of increasing prep, and that are also going to be hurt by this 340B change as well. So just want to recognize that as well. But you know, I know that this is a much bigger issue than necessarily this council can think about addressing, but it does feel like always this is going to be an issue in states like Tennessee that hasn't expanded Medicaid. And, you know, it's just not as, this isn't as big of an issue in places like California that have more funding available to them for these sorts of things. So to me, it sort of feels like that's the ultimate goal and something that would really help with a lot of our EHE initiative, but I know that it's unlikely to happen anytime soon. Brady, did you raise your hand?
I was just going to say, you know, I think one part that we are missing out of this conversation, and that needs to be part of the conversation, is prioritizing the lives of people who are living with HIV. And because if we are prioritizing people living with HIV, if we're increasing testing and getting people in treatment, then there are not further transmissions happening within the community. And I think that aspect of the prevention conversation isn't being included. We're just talking about PrEP and PEP, which is great and it's absolutely necessary, but we're not going to end the epidemic unless we do prioritize people living with HIV and do those, you know, really hit the systemic racism portions of why these people are not in treatment and not receiving care. We're just going to keep running in circles.
Good point, Brady. And I think the prevention committee that you talked about, Claire, might be a really good place for folks to sit down and really look at this kind of throughout the whole continuum from prevention to care and treatment of what needs to happen in Nashville as we look at this comprehensively. And just, I think a lot of states have done that with their EHEs, is to really take a look at it and really do a hard assessment of really what's working well, what have been the successes, and where the true gaps and problems are. And I think for us to say we're addressing, you know, racial equity and diversity and inclusion as part of this is to, as leaders and even this EHE, to really take a hard look. And I love Leah's presentation, but what's the baseline and what are some of the true things that we need to be doing, and really having a candid and honest conversation about what we need to do in this community in order for us to really end the HIV epidemic and move the needle.
Yeah, it's a great point. And I think as I've been thinking about the prevention work group since Friday, I've been in, you know, in an ideal world, I think that prevention work group is actually like 4 different work groups in one. You know, there's PrEP, there's PEP, which it could have a project all on its own. There's people living with HIV and that viral suppression aspect of ending the epidemic and prevention in that way. And then there's also the whole other issue of equity in prevention, and that's multiple projects in itself as well. So I think my hope is that it starts as one work group, and you know, hopefully a lot of people will engage in that, and enough people will engage in it that they can break off into more focused groups that can deal with some of these more specific and really important issues.
We've brought up a lot of scoping issues today, which I think are all really important. And this is just one to add, and I don't know if there's already have been discussion in the past about the criminalization laws in Tennessee, and what type of advocacy we can promote for that. I've been hearing more and more and more about this recently, and how it's impacting, how providers and DIS and EIS outreach workers supported by the state are required to counsel people living with HIV about the risk of criminalization and how it's being sometimes done in ways that are really, really not good. But the fact that it exists at all in this state is really something we need to, I think, also address. So another item to, for other calls, but I just wanted to make sure I brought it up because I don't know if it's been a topic of discussion already.
And Leah, to go on to that, the Williams Institute, there was just within the past couple of months a really jarring report that was released and done by the Williams Institute showing the impact of criminalization in Tennessee. They looked directly at Tennessee, and the numbers coming out are showing, that it's mostly Black women who are more negatively impacted by HIV criminalization laws, and Black men. But I don't know if this council has seen that report, but it would be, I'll get it to you, Claire, or Morgan, and see if we can distribute it to the group. But there is a lot of jarring data in that report.
Yeah, thank you. Please do share that. I would love to see if the authors of that would be able to do a presentation for us.
I'm not sure if it's the same people, but we had an ID grand rounds or nope, it might have been CFAR. Someone came recently to Vanderbilt, and she may have been affiliated with that group, but it was summarizing that same kind of data. So if that's not an option, I'll make sure I put you in touch with that person too, Claire.
Yeah, that'd be great. All right, if I know we actually did take our whole time. That was a really wonderful discussion. Thank you all for hanging on for that. I just want to ask if there are any final thoughts before I pass it back to Dr. Bullock to wrap up. No? All right. Over to you, Dr. Bullock.
Thanks, and thanks everybody for just a great discussion. We made good use of our last 30 minutes. With a lot of really good discussion. So we do need to back up to the minutes. So I think we do have quorum now. So if everybody had a chance to review the minutes from the last meeting of August 4th, and there are no amendments, I'll take a motion for approval with a second as well.
I move to accept.
Is there a second?
Second.
Okay. And I will just take if there are any objections, and if not, then we'll just assume that everybody else is in agreement. Does that work for you, Morgan? All right. Minutes from our last meeting are accepted. Are there any other questions, comments, or announcements to share from the group? Any upcoming events?
Yeah, this is Abna. I'd like to announce on World AIDS Day, we're bringing Jeannie White to Tennessee. And so we will be really excited if everybody could join us. I think it really reminds us why we're all doing this, and the courage from her son, Ryan. And just to remind us that if a young, 13-year-old was courageous to advocate, just to kind of reinvigorate us and just, share the stories and let clients know we're inviting our clients and staff and trying to get all of our partners to come and join us to hear this. So she's really excited. So if you want more information, you can go to our website, www.nashvillecares.org. We're selling tickets. And so we're hoping to get as many people there. And I think it would be a really, really great event for all of us to come and hear her story about her son. So sending an invitation to all of you and your team members and anybody
Where's
else.
that going to be?
It's going to be at the Music Hall of Fame. So it's all on the website. And so we can actually hold up to 500 people. So I think it's going to be really exciting. And our clients are really excited to join. So if you have any clients that are interested, trying to really get some sponsorship, so maybe folks can sponsor clients to attend. It'll be a breakfast, so it'll start at 7:30, and then we'll start, Jeannie White will start speaking at 8 o'clock.
Thank you, Amna. Anybody else have any additional announcements?
then
I
that same
just
week
want to
for-
let y'all,
Go ahead, Morgan.
I want to let you know all know that the Fast Track Cities Conference is happening next week, and I'll be sending information about that. I think Dash has emailed some of you all, but we do have free registration codes for a few people left from Nashville. So if anyone wants to attend the conference, you can let me know.
And then the same week, World AIDS Day, on that Saturday, December 3rd, we're going to be holding our second annual Ruby Gala at Marathon Music Works. Tickets are on sale now. I think everybody on this list should be getting an invitation soon in the mail.
Thank you. Anybody else? I think our calendars are already filling up for the rest of the year. All right, I do not have anything additional. So thanks everybody for joining us today, and everybody that was on that is new as well. Our next meeting, originally scheduled for December 1st, will be probably shifted a week back. So we'll wait on Morgan to send out that confirmation. Until then, I guess this is our last meeting before at least the Thanksgiving holiday. So happy fall and happy Thanksgiving to everybody. And we will see you probably the second week of December. So have a great rest of the day and rest of the week.
Thank you. Thank you. Bye, everybody.
Thanks, everyone. Bye.
Everyone.
Bye.